It is Wednesday, June 16th, 6 p.m. This is Anatomy and Physiology, 6NAX, MED210, and it is week 4. Excuse me. So, task 3, discussion 3, and lesson 3 is due today. We'll be doing the 4th week of topics, and there will be, I repeat, no lesson 4. Do not do lesson 4 because next week is midterms. Okay, and the midterm will be performed online. And the way it'll be performed online is this is how it goes. Let me write in person who just checked in. Okay, there's 5 students plus me is 6. So this is how it's going to go down for next week. So next week on Wednesday, June 23rd at 5:55 p.m., you will go into your announcements. You click on announcements and it'll say week 5 actual midterm exam. You'll click on the midterm exam and there will be a Microsoft Word document. 50 items, multiple choice. You take the exam during our class time, and then you submit the answers via, what do you call that? Yes. Hello. Welcome, welcome. Let me write down Miss Jones. Cool. All righty. So when you submit it, you submit it via email, of course, and you just put it in the body of your email, numbers 1 through 50, and your answers. That's it. You don't take a picture of your answers. You don't send me back the Microsoft Word document. You just write down in the body of your email numbers 1 through 50, and those 1 through 50 should correspond to your answers. That's it. And you need to do it by 7:15 p.m. that same evening, Wednesday, June 23rd. For every minute that you do not submit, minus 1 point. You can take the exam early if you wish. You can give me a call or an email to have that request, and but you can't take it late. So if you miss it or whatever happened that night and you didn't get in touch with me, by the weekend, well, the grade has to be a 0 for it, and that's 10% of your grade. And if we're only halfway through the term, 10% of 50% is that's already a significant hit to your grade. So don't be that person. Every term, there's always one that misses it. And please always check your announcements, because there's job opportunities, there's extra notes, there's always something in there of worth or value. And good on the people who noticed that, the other night, I immediately got word that, hey, Dr. Garais, the Zoom recording isn't working. So immediately after it gets posted, check to see if it's working. Maybe it's just not working for you. Or maybe it's a global problem. Another thing that I'll also be doing this evening as well is, along with the recording of this session, I will be posting an actual midterm exam that I gave maybe a term or 2 ago. So it'll give you an idea, for those of you who haven't had me before, what to expect. And again, the format is items 1 through 50, multiple choice. And it will be administered starting 6 p.m. Wednesday, June 23rd, and it will be due by 7:15 p.m. same evening, and all the instructions will be located here in your announcements. Does anyone have any questions on how next week is going to go down and what's due next week?
No, sir.
All righty, sounds like a plan. And if, of course, you can refer back to this video or look at the announcements, because you guys know I try to double up any announcements. Now, another public service announcement is that registration is also open. So if you don't know what classes to take next term, please get an email, please get a call out to your academic advisor. If you don't know who that is, you could shoot me an email and I could find out. But if you're Alexandria campus, BS Health Science, and a nurse candidate, odds are it's me. And if you're a nurse candidate, you should have your BSN transition plan, okay? And then I can help you update that. But that's not an official plan. Well, it's semi-official. It's something to help you know what classes to take. And if I am your advisor, just tell me, oh, I want to take this class or this other class. I'll register you. It's faster that way. But if you want to register yourself, give me a call and I'll give you, I have this like PowerPoint with step-by-step instructions that can help you. But honestly, lately the student self-service portal has not been as reliable as it was in the past, because they're revamping things and making things faster and better. But as they're doing that in that construction, it's been causing some students some problems. But if you're an Alexandria student, best bet, just tell me, I'll register you. Okay. So give me a call, shoot me an email or something in the next couple of days. If you either don't know your class, don't know how to read your BSN transition plan, or if you just need help knowing on who to contact regarding registration or any of your nursing submission items. Okay. All right. That's my public service announcement. Oh, what are we doing tonight? And remember, and again, I got to reiterate, do not do lesson 4 for next week. You should be only handing in task 4, discussion 4 for next week, because you have you got a midterm to do. So what are we doing this week? We need to know about urine and the urinary system. Chapter 25 in our ebook, and how does it transport? Why is it important? And the function of the kidney. And this thing right here, I don't like this this video too much. There's actually a better video. I'm on the curriculum committee for this. I already have a better video. And actually, I have a better diagram, which is better than any video. And you could find it on Google, and I could show you how. Because we talked about in the past endocrine regulation of your RAA system, your renin, angiotensin, aldosterone system. And I find this video a little bit, I don't know, a little bit confusing. And as usual, if you look at here, the urinary physiology lab, please don't do the lab. But there's these lovely notes. They're like quick notes, okay? And they're a little bit easier to read than the chapter itself. So urinary system structure and function, kidney structure and function, endocrine regulation of kidney function. Doesn't all you hear is structure and function? Because of course you're in an anatomy and physiology class. Okay, let me do 1, 2, 3, 4, 5, 6. 6 plus 1, 7. That's me. All right, just checking over attendance. So let's go over, what was it, chapter 25? Let's go to chapter 25 in your, let me turn things around, in your textbook. So we look here at our open stacks. X out that, table of contents, and then I scroll down on the side, and it should be chapter 25, 24, and 25. Click on that. Get rid of this. So these are our goals. What's urine? What are the structures of the urinary system, right? What are all the parts? We're going to talk about the macroscopic and microscopic. Another term for macroscopic is the term gross. If you ever want to go to medical school, there's a course called gross anatomy. Gross doesn't mean it's like gross or disgusting. It just means that it's something where that has weight, or you could see it. And that's your macroscopic anatomy. We're going to a little bit of the trace following our blood. We're definitely going to know what is the dirty blood and what's the clean blood. And what do we mean by dirty and clean? We're going to talk about these three functions: filtration, secretion, and reabsorption. And that is in this thing called the nephron. And this thing is called the nephron, and it's the functional unit of the kidney, and it is microscopic. We have millions of them. We're not going to talk about portal system or osmolarity, but we are going to talk about how urine and blood pressure regulate each other. And not too many of the major ions. It's a little bit much. And just a little taste of how the kidneys also manage acid-base balance. So let's go over. I don't want this. What's this? What's going on? What's going on? I don't. Why is my screen too small? Maybe I can, hold up. There you go. Okay. So what's urine? Urine is the byproduct of your kidneys. And whatever ends up in your toilet is considered waste. Now, what does the body consider waste? Anything that is extra. So start to look at waste like urine and feces is just, they're not really dirty things. Of course, you don't eat them or drink them, but they're just the byproducts of our metabolism and also part of the balance that our body must maintain. So, for example, you drink a ton of water. What's going to end up in the toilet? A whole bunch of water. If you're diabetic and you have way too much sugar, what's going to end up in the toilet? Sugar. If, let's say, you have way too much proteins in your blood and then the kidneys filter it out, what's going to end up in your urine? Of course, proteins. So when we look at urine, its color should be like pale yellow, the deep amber, depending on the concentration of your urine, and depending on if you drank something or you didn't drink something, or you're holding your urine or not. The odor, I don't agree with this term, odorless. The term for normal odor for urine is the word aromatic. Now, what does aromatic mean? It means urine smell. And we all know what that smells like. Now, this is not a clinical class, but anything other than, your typical urine smell, like what's an abnormal urine smell? Which foul. Foul smelling smells like hot garbage. It's what does it smell like? Kind of smells like, you rotten fish that you left outside in the middle of August. That's foul smelling. You don't even have to get near the urine specimen bottle to know that something's incredibly wrong. And of course, the color, it should be clear. If it's cloudy, most likely your patient has hyperlipidemia, meaning they have way too much fat. And if you have way too much fat in your blood, what's going to end up in your urine and in your feces? Of course, fat, because it'll be considered a waste product. The volume is variable. It could be as small as like half a liter to almost 2.5 liters in a 24-hour period. The pH could be either slightly, slightly acidic or slightly basic. And remember, the definition of pH 7, around the pH of 7 is where humans should be, around 7.4. So depending on what you're drinking or what you're eating, the pH should be slightly acidic or slightly basic. Another word for basic is alkaline. Specific gravity means like how heavy is the urine compared to water. Water has a specific gravity of 1.000. So you could look at this index as urine should be really close to water. There shouldn't be a lot of stuff in there. Osmolarity just means like how much like particles or solute is in your urine. And again, it shouldn't be a lot. If you see milliosmoles means in 1 kilogram, it's not a lot. And that's why your specific gravity also isn't high. Urobilinogen, it's part of a metabolic process in your body, and also contributes to the yellowish amber, pale yellow or deep amber color of your urine. White blood cells, you should have almost none, because in your blood, you shouldn't have a lot of white blood cells. But if you have an infection, what are you going to see? You're going to see a lot. Leukocyte esterase, that's an enzyme that deals with white blood cells, again, related to white blood cells. You shouldn't see them. But if my patient has an infection, these two things should shoot up. Proteins, you shouldn't have any, because proteins, your body should use them. Bilirubin is also like urobilinogen, is also a metabolic byproduct, which also contributes to the color. And it's part and parcel of the breakdown of your red blood cells. Ketones, we talked about ketones before. You shouldn't have any. If you have ketones in there, you're either diabetic or you're in a starvation state. Nitrites are nitrogens. Now, another thing you're going to hear about the urine is that it throws out nitrogenous waste in the form of ammonia. But you shouldn't see nitrites. And again, too much proteins, too many nitrogens, too many nitrites. That's not a good thing. Blood, it should be filtering the blood, but it shouldn't be leaking blood. And glucose is something really important. Unless you're diabetic, you shouldn't see any glucose in your urine. So this is a wonderful chart on what normal urine looks like. I could ask you, what would be the normal color? What's the normal pH? You could be slightly acidic, slightly basic. Specific gravity. And you don't have to memorize the numbers. Just know that you shouldn't see proteins, you shouldn't see bilirubin, you shouldn't see ketones, nitrites, blood, or glucose. You should see very little white blood cells or leukocyte esterase. The osmolarity and specific gravity should be very, very mild and should be very close to water. Okay? And remember, the normal odor for urine is urine smell, which is aromatic. Where's my Microsoft? The word aromatic. But nowadays, people just write normal. Now, the color of urine, we just mentioned, it varies. It could be very, very light to deep amber. Because if my patient's very, very much hydrated, if I remove the water from the system, the number of solutes would dominate and it would change the color. Urine volumes, just know the medical terminology. Just know that polyuria means my patient is urinating too much. Oliguria, my patient is beginning to have a decreased urine production in a 24-hour setting. This is very dangerous because it's impending kidney failure. This is, or significant dehydration or blood loss. But when I see this, I see oliguria, I get very, very excited as a clinician because I'm thinking kidney disease. And anuria, guess what? You're already there. How many times overnight I ask a million times whoever is on duty monitoring my patient, you know, at 10, 11 o'clock, midnight, everything's okay, everything's cool. At 4, 5 a.m., I ask, what's the urine volume? And they go, oh, we didn't take it since 11:30. And then we find this. We find it was almost nothing in the last 12 hours, to 12 to 24. And that's impending kidney failure. No, actually, in my book, that's kidney failure. when it gets that low, 50 cc's in one day, or even in 12 hours, that's crazy. That's not good. Okay, that means your kidneys aren't doing its job. And as long as you have blood flow, as long as you have blood pressure, you should have urine. So now we know what urine looks like. Now we know some generalized terms. Let us look at the anatomy. Now, why'd they do it this way? Okay, this is what I'm going to do. Give an overview first. And then we're going to talk about the separate pieces. So the overview of the urinary system looks like, what's a nice one that's not too complicated? Ooh, this one. I like it because it has some little touch of realism here. Oh, it's on. And it doesn't, you know what? Let's get a diagram that's very, very basic. There you go. Of course, you have two kidneys. You have, I'm looking at my patient. This is the right one. This is the left one. And they kind of drew it here. Why would the right kidney be lower than the left? Would anybody know? You could call it out or put it in the chat. Why was the right kidney lower than the left? They drew it a little bit subtle, but it's a little bit more than this. What's the big organ that's here? In your right, above your right upper quadrant?
The liver?
The liver, correct. And since it's so big, it'll push down on this kidney. Now, you have two kidneys. You don't need them both, but it is optimal to have two. You can live without one, but it's not a good situation, and especially if the remaining kidney isn't performing very well. After the kidneys, you have these tubes, and it's exaggerated in this photograph, in many photographs. If you recall your anatomy and physiology one, remember when we were messing with the kidneys? It's almost like a string. It's very, very thin. So you have two ureters. Now, don't confuse ureter with urethra. This is your urinary bladder, okay? And then, of course, from your bladder, this is the temporary storage of urine. From your bladder to the toilet is a tube here called your urethra. And then that brings us to these two pictures. So if you look at the urinary bladder, and then you look at this urethra, right, for my female patient, then you look at the urinary bladder, and then you see the urethra for the male patient. Of course, the male patient, significantly longer. You could also see that the urethral meatus, or the opening, isn't as close or as exposed to the anus and or vagina. So the predisposition for a UTI is greater in your female patient for that very reason. And also you could see the differences between the short, relatively open introitus here for your urethra versus your male patient. Now, what is the function? I think that's kind of going backwards. Of course, the function of the urethra is the delivery system from your urinary bladder to, of course, the outside world. Now, the urinary bladder. The urinary bladder is made up of transitional epithelium, meaning this thing can blow up like a balloon, and not blow up as in explode, but it can expand. And if you recall that one last chart that we looked at regarding volumes, in a typical day, it could be as small as what? Less than 500 cc's per day, urine. Actually, if you're not drinking at all and want to dehydrate yourself, your urinary bladder can be as small as a golf ball, and it could hold anywhere to 2 to 2.5 liters when it's expanded. And what helps us do that? This transitional epithelium. So this, the epithelium and the muscular layer that's here, it expands, okay? And the function of this bladder is temporary storage. Now, urine, when it comes out, in theory, it's supposed to come out sterile. But we all know that if you have any fluid that's warm and full of salts or some things in it, you know something's going to grow in it eventually. So when urine comes out, it's considered sterile. But just know and understand that if urine gets stuck in here for whatever reason, it predisposes to for a UTI, and UTI is urinary tract infection. So a UTI would be any problem with any part that we just talked about except the kidney. So it could be a ureter problem, ureteritis. It could be part of a bladder problem, cystitis, or it could be part of a urethra problem, urethritis. So those are typical urinary tract infections, and they don't necessarily have to be sexually transmitted, because like I said, if you just keep urine in here, you hold it too long, it's gonna start growing things that you don't want to grow. Now, micturation is another word for urination. Another word for urination is voiding. So to have your patient void. Now, it's a reflex. When your body senses that your urinary bladder starts getting full, what's going to happen? There'll be increased pressure down your urethra, and your urethral sphincters. If you recall Anatomy and Physiology 1, you have an internal, external, just like your anus. Your anus has a sphincter. There's an internal, external. Now, do know and understand that these things, you can voluntarily hold your urine, okay? But eventually, this pressure and the micturation reflex will win. So it goes, and again, not advisable to hold your urine. It's not a good thing. Now, the nerves that are involved with urination and that particular area of your pelvis are your sacral nerves, S2, 3, and 4 specifically. And you could see how they connect into here. And you could also see if you have a lumbosacral damage. A classic one is I had a patient, he used to ride one of those, those racing motorcycles, and he hopped up 20 feet and then landed on his groin right on the motorcycle, going about 80, 85. All this got shattered. Guess what happened to the pudendal tributary of his S3, S4 nerve? It got cut, and then what happened? He could no longer, well, this is a she here, but can no longer control micturation, voiding, or urination. So that is your sacral nerves that's in control. Now, your ureters. If you look at the ureter, it's surrounded by small, smooth muscle. We cannot control smooth muscle. It's automatic. Now, if you look at the lumen or the hole of your ureters, it's not that big. And the majority of that tube is what? Smooth muscle. Now, why do we need smooth muscle? Because we need peristalsis. These are the coordinated contractions to help kind of milk and push urine down into the urinary bladder. And those are your two ureters. Oh, let's go back here and just have a clinical correlation. Now, remember we used to talk about stones in Anatomy and Physiology 1? If you had a stone here, what do you think it would do to all of this? Because remember, the stone is quite large. They can be large. And this lumen is like, I don't know, barely 1.2, 1.3 millimeters wide. So it'll scrape and cut all of this. And that's why kidney stones are very, very painful. My wife just had kidney stones, and she said it is comparable to childbirth. And she's a tough cookie. So for her to say that it hurt, that's something. Now, our whoever created us is really smart, because our kidneys are located retroperitoneally. Now, what does that mean? Let me write down that word so we can break it down. Now, your peritoneum, of course, is the covering surrounding your abdominal cavity, covers everything. Whoever built us smart and put the kidneys behind that covering, all the way in the back, and protected by our floating ribs, which is ribs 11 and 12. And so they're very much protected back there, because it's the urination and your kidneys and the jobs that your kidneys do are extremely important. So let's get down to its internal anatomy, which, by the way, next week, wait, there's how many of you? There's 7? Let me count. 1, 2, 3, 4, 5, 6, 7. Okay, I got you. I got everybody good. So let's look at this. Now, I guess that's the largest I can make it. Okay. When you're looking at the internal structures of the kidney, this area right here is called your hilum, Hilum. And it's important. That's the indentation of the kidney. And it's important because remember that motorcycle guy I was telling you about? I had another motorcycle patient. You know, when you roll on the ground at like 100 miles per hour, what happens? It creates inertia, or actually it creates not only inertia, but it creates something called centripetal force, right? And it'll rip all this stuff out. So if for a lot of acute renal failure, especially regarding like motorcycle accidents, or the patient got thrown from a car, it's really common. Oh, by the way, anybody here on this call ride motorcycles? No, nobody. Well, did you ever notice maybe you saw like a motorcycle jacket? They're not only cool, they're really important because they're heavy. So when you fall, it kind of pads you a little bit. But a good motorcycle jacket has these ribbings in the back that keep your waist tight, and just like a fighter pilot, because you don't want this stuff to be ripped out. So what's this stuff? Of course, from your kidney down here, that's your ureters. It's going to transport whatever urine that the kidney makes down to your urinary bladder. You also have a renal vein and renal artery. For the exam and for the textbook, it's colored blue for renal vein and colored red for renal artery. Now, another thing, of course, you're going to have, of course, renal nerve, because wherever there is an artery, there's also a vein and there's also a nerve. VAN, vein, artery, and nerve. So, of course, this is your kidney. So this got to be renal artery. If I point at this red thing, it's got to be, point at this red thing, it's got to be renal artery. Point at this gold thing, it's renal nerve. Point at this blue thing, it's renal vein. Now, dirty blood comes in through the renal artery, and it comes up here, and each one of these sections is called a lobe. So it comes up through the interlobular or interlobar blood vessels. Here, artery, of course, dirty blood. Then it gets into the cortical blood vessels, and then see how this forms like an arch, or your arcuate blood vessels. And in this area here, which is known as your cortex, that's where those 3 important things happen on that outside rim. That outside rim is called your renal cortex. And it has three major functions: filtration, reabsorption, and secretion. Now, filtration is easy. I'm going to filter stuff. I have dirty blood, quote unquote, dirty blood that has nitrogenous waste in the form of ammonia, and I want to get rid of it. So, of course, the renal cortex part will filter it. And then sometimes we throw out something that that we shouldn't have. Like, let's say, for example, I accidentally threw out some glucose, but then I'm like, oh, I'm going to be starving later. So I am going to reabsorb it. So because this filtration process isn't 100%, so whoever built us built up two backup systems to this filtration process. And all three of these things happen in the renal cortex. So filtration is we filter out the blood for ammonia or nitrogenous waste coming up from the renal artery into your interlobar arteries, into your arcuate arteries. And then it goes into the renal cortex, filters it. Reabsorption, that's when we take back something that we maybe shouldn't have thrown out. And secretion. Secretion is we definitely want to throw out something. Let's say, for example, oh, I had a whole bunch of Doritos. We definitely want to throw out more salt. So what's going to happen? It's going to secrete more salt. So filtration, of course, filtering, reabsorption, taking back something. Re means back. I want to reabsorb. I want to take back something that I accidentally threw out in my filtration process. And then last but not least, oh, I forgot to throw this thing out or that thing out. And that's secretion. Filtration, reabsorption, secretion, and they all are performed, and we're going to talk about the nephron momentarily, and they're all in this area here on the outer rim of your kidney, and that area is called your cortex. Now, that's what I call the blood side. Now, the urine side are all these funnels here, and that's all that it is. If you really use your imagination a little bit, doesn't this look like a funnel that goes into this funnel, that goes into this funnel, and then this big funnel, and then it goes right down here? And this area is called your papillary area. So you have your cortical area, and you have your papillary area, which is here. Now, let's look at the papillary area, and let's look at all the funnels. So this first funnel is called a pyramid. Use your imagination a little bit. Doesn't it look like an upside down triangle? And then it goes into this little funnel here called your minor calyx, and then into a bigger funnel, which is obscured here by your renal artery and renal vein, and that's your major calyx. And from your major calyx into this area right here that's obscured by all these, and that's your renal pelvis. And all of that is part of this medullary or papillary area. And they call it papilla because you got these little papilla or little fingers. So this area, medullary, also known as your papillary area. And that's the area of all the funnels. So let's go over all the funnels again. Pyramid, minor calyx, major calyx, down into your renal pelvis, and then finally down your ureter. So what can I do with this? Can I erase all of this? A, B, C, D, E, F, G? Sure. Can I have a question like I can erase all this? What are the structures of your renal hilum? And there's 1, 2, 3, 4 structures in there. Doesn't that look like a beautiful all of the above? I could ask a physiology question. Is the blood coming in the renal artery, is it clean or dirty? It's of course dirty. How about the blood going out into the renal vein? It's clean. Who cleans it? Well, the cortical area. Okay. And what were the three functions in our renal cortex? Filtration, reabsorption, secretion. Let's take a little pause. Does anyone have any questions on how I could ask a question like this on next week's midterm? I could make it a straight up anatomy question, or I could make it a physiology question. I could ask, hey, this renal pyramid, what's its function? Oh, it's a funnel to funnel urine. This urine, 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 urine. But what's all happening here in the cortex? That's blood. Blood that gets filtered out, reabsorbed, and secreted, and then it'll create urine. Okay. All right, let's pause for effect. Let me take a quick bite of my cold pizza. Okay. Remember the cortical area right here? Well, it has a whole bunch of these, and I forgot. Let me see how many nephrons. It has these things called a nephron. This whole entire thing right here is called a nephron. And there's like, I forgot, millions. We'll say here. Forgot the millions or just know that there's a ton of them. And they're all microscopic. And what do? They do the three processes that we talked about. So let's look at it in this grand detail. So we talked about the three processes right here. Filtration, reabsorption, secretion. Well, filtration happens at the level of the glomerulus and the Bowman's capsule. Where's that? This tuft or little tuft is like kind of like a big tangled ball of capillaries. And they're very small. And it's really neat because things can go in and out of here really easy. So you got dirty blood coming up my interlobular artery. We know that it was coming from my renal artery and it came up in here into my cortex and it found one of these glomerulus. And then what happened? Well, filtration happened. Anything that was extra or any nitrogenous waste will go through the Bowman's capsule, which is this capsule right here. And then we'll head down these tubes. Now, going down these tubes, you can also see all the capillaries are closely related to it. Because remember, when we're going down these tubes, what are the other two things that we're going to have to do? I'm going to have to reabsorb something that I may have thrown out by accident. So let's say, for example, remember we talked about glucose? Glucose was traveling around, and then they're like, oh, wait a minute. I need that. I need the glucose. So you'll see while it's traveling down here, don't you think it might go back in? So that's reabsorption. Now, what's secretion? Let's say, oh, I definitely want to get rid of salt. So, of course, what happens? Salt will go out, and that's secretion. So the renal cortex is filled with a whole bunch of nephrons. Nephron is the functional unit of the kidney. I cannot type. It's microscopic. There's millions of them in the cortex of your kidney. And you can see here, what is it doing? It filters the blood. Then, through a whole bunch of other processes here, it will reabsorb and secrete. And then at the end of the day, with all that fluid, right? Water and salt go here in the loop of Henle. You have the proximal convoluted tubule, loop of Henle. Let me write that down. So that's that big long loop. Now, the loop of Henle has something called the countercurrent, which deals with salt, water. Okay. So I could ask you on exam, where's your proximal convoluted tubule? Oh, it's this stuff here. Where's your distal convoluted tubule? Oh, it has to be this stuff all the way out here. So proximal, meaning closer to the glomerulus, distal, meaning distant, and who's in the middle? This big, long loop of Henle. And we're going to be talking about the loop of Henle in a little bit more detail in a moment. Just know for now, for this stage of the lecture, you have the glomerulus, Bowman's capsule, proximal convoluted tubule, distal convoluted tubule, collecting duct, and loop of Henle. I could easily take this, make it A, B, C, D, E, F, G. And looky here, a whole bunch of collecting ducts will eventually end up where? In the pyramids, renal papilla, minor calyx, major calyx. So just imagine 1 million of these things leaking all waste and all urine and anything we need to get rid of through all these little tubes. And you could also see it's intimately connected to blood. So the kidneys are super, super related to your blood pressure, super, super related to your cardiovascular system. And if your cardiovascular system starts to fail, guess what? It goes, this is going to fail too. And just like, what do you call that? You know, like a conveyor belt. If one person on the conveyor belt messes up, everybody or everything in the process downstream also gets messed up. And that's pretty much how your body kind of works or doesn't work regarding pathology. Renal corpuscles, just nice to know. Oh, here's an expanded. And you can see here, it's like a tuft of capillaries. This is a, what do you call it? Glomerulus. This is the Bowman's capsule. And right here are your JG cells, and they have to do with your blood pressure. And we're going to talk about that in a moment. Now, one of the things that we measure is the glomerular filtration rate, or your GFR. Your GFR is an important test because it gives me direct number on the status of your filtration function of your kidney, which is the star of the show. And the nephron is definitely the functional unit of the kidney and the star of the show. We're going to be talking about the RAA system momentarily. And we talked about loop of Henle. Let's now talk about, I'm going to do RAA next. Now, this is just for future reference. Remember, get the basics first of what this does, filtration, and what this does, and your glomerulus and your Bowman's capsule. Because you're going to see here, if ever you guys want to take your MCAT, you're going to have to memorize all these pressures. Now, we already know how things work. Everything works from what? High pressure to low pressure. Remember when we were talking about osmosis, how it goes through a membrane? Look at the blood hydrostatic pressure. It's 55 millimeters per mercury. Colloid osmotic pressure and the capsular hydrostatic pressure. It's all greater than what? The pressure of the Bowman's capsule. Therefore, right, the hydrostatic pressure will go where? This way. It goes, so the net traffic of urine should go what? This way. And you'll be memorizing those numbers in the future, but not for my class. And you'll be doing math. So, and also nice little message. If you're not good at math, get good at math. because and you don't need to be great at calculus, but you really need to know like basic algebra. So when you take your Math 111 class, please, it may feel like busy work and you're like, I remember this, but remember, what's the function of education? You're going to need it. You're going to utilize it. And especially future nurses, what do you think you guys do all day? You check everyone's math. That's one of your main functions, especially when we're dealing with lab results and pharmacology. Here's a nice little diagram. And again, you don't need to know it at the level of this, but know and understand that certain things go in and out of certain areas based on chemistry. And if you look at the loop of Henle, what's really important in the loop of Henle, in the first part is water. In the second part, or the ascending limb, it's salt, sodium, potassium, and of course chloride. And remember, sodium and chloride together make what? Table salt. So it's another way to for you to remember it. And it forms a countercurrent, and I'm going to show you what that means momentarily. So let us now look at, oh, and this too. I don't want to show you that. Take your biochemistry, then you guys go deal with it. Okay, let's talk about the countercurrent. The countercurrent is in the loop of Henle. And what does that mean? It's going to be an alternating current, right? If you look at here, osmolarity means like how much solute or how much concentration of salt is in something. So in the first part of the loop of Henle, water goes out. Can we all see that? Water is going out. Now, as water goes out and urea goes in, right, which is our waste product, right, which is a nitrogenous waste, what's going to happen to the concentration of the salts? Of course, as more and more urea gets in, the concentration will get what? Higher, 300, 500, 700, 900, 1100, 1200, right? But then on the ascending, what's going to happen? Sodium and chloride will now go where? Will go out of the tube. So what will that do? If I start taking out the solutes, it's going to decrease the osmolality. So if it does that, the concentration is going to go what? Less, 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 and less. And that's how it works. Water goes out on the descending limb. Urea or nitrogenous waste goes in. And then on the other limb, so that urea and the nitrogenous waste stays in here, sodium and chloride and a little bit of potassium does what? Goes out. And you have to be amazed by this. This shows that we are all designed like a machine. This can't get any better than this. And for future reference, you're going to have this again in your pathology class. And oh, by the way, this countercurrent is on your NCLEX. They're going to ask you things like, what is the typical osmolarity in the first part versus the last part of your descending limb? And if you know it, know the picture, of course, it's what? Not as much. And then it gets highly concentrated here. And then the urea gets traded in for what? Sodium and chloride. And it also shows homeostasis, the balance of the human body. Whatever has to go in has to go out. Okay. And of course, we reabsorb some water here on the descending limb. So how could I ask this question on the exam? I could ask, where does water and salt retention and secretion happen? And you'll tell me where. Loop of Henle. What's happening in the descending limb? Well, water is going out, urea or nitrogenous waste is going in. Okay, what happens in the ascending limb? Well, water gets to stay, but who goes out? Sodium and chloride. That's the worst I could do to you, but looking at this picture, it's really neat and it explains a lot. It explains a lot, like why do I have water in my urine? Why does the medication that deals with me peeing mess with my sodium and mess with my chloride, mess with my salts? Why does high blood pressure mess with my salt? And remember, wherever sodium goes, water will go too. Okay. What's next? We already went through nervous system. You know, it's S2 through S4. Oh, lovely. The renin, angiotensin, aldosterone system. All right. So take a deep breath because this gets interesting. Now you're going to look at this chart and you're going to go, what the fudge? Oh man, do I have to memorize that? Yes. But I'm going to show you how to break it down. And it's going to look like a concept map. Where are you? Where is my favorite RAA? Because it's simple. Bingo. Let's take this. Put this here. All right. Let's make this big. Can everyone see this? So what's RAA? It's hormones, renin, aldosterone, and angiotensin. It's called the Raa pathway. Its function is to regulate blood volume and blood pressure, and as a side effect, sodium, potassium, and hydrogen ion levels. Now, when we're just looking at this right now, right, which is part of your kidney, so if it's regulating blood volume, it's definitely going to regulate blood pressure. And if it's regulating sodium and potassium, remember, wherever salt goes, water goes. So if I retain my salt, right, what will happen? You start bloating up, right? And your blood pressure will go up. But if I throw the salt out, what will happen? My blood pressure will go down, blood volume will go down. And also, if I mess with my H+, if you recall the definition of pH, which is the negative log of the concentration of the hydrogen ion, that means what? A lot of hydrogen ion, acidic. Not a lot of hydrogen ion, basic. So this is an all of the above question. What does the kidney do? Well, it not only does that filtration, secretion, and reabsorption thing that we talked about, regulates blood volume, blood pressure, salt retention and secretion, and also acid-base balance. And then on top of all that, the kidney also monitors how much blood you have in your system. So it signals hematopoiesis, meaning if I'm a little bit short on my blood volume, what will my kidneys do? It will tell my red marrow in my bones, hey, we need more blood. So let's say, for example, you lose a significant amount of blood. A classic example would be any surgery or childbirth, right? Childbirth, well, almost 300 plus cc's you can lose. It's hefty. So if I lost some blood, what's the signal from my kidneys to my bone marrow is, hey, you need for me to make more blood. And that's what endocrine system is. It's a signaling system. So we're looking at this. It looks a little crazy, but I want you to look at it just like you look at your concept maps. Can you see this is just one section here? Can we all agree to that? Can we see this is another section here? And this is a third section that has two parts. Can we all see that? Now, how do you learn something that's complex? You break it down into parts and you know it versus memorizing it. So if I'm looking at this first part right here, we know that if I'm dehydrated, or if I'm bleeding out, or if I don't have a lot of sodium, what happens to my blood volume? Remember, wherever sodium goes, if I'm throwing out sodium, what's going to happen to the water in my system? It's going to be out. If I'm dehydrated, what's going to happen to the water in my system? It's going to go out. It goes, if I'm hemorrhaging or bleeding out, what's going to happen to the blood volume of the water in my system? It's going to go out. So just like a hose. If I decrease the amount of water in that hose, what happens to the blood pressure? It should decrease. So we know all of this is related. Okay? Blood, salt, and water. They're all related. So what's our signal here? If I have a decrease in blood volume from either dehydration, sodium deficiency, or hemorrhage, of course I'm going to have a decrease in blood pressure. So that's one step. So this is the stimulus. Who activates the RAA system? It's what? Decreased blood volume, decreased blood pressure. Okay? Now, can I ask a decreased blood volume, decreased blood pressure question here? Yeah. Joey has a significant decrease of blood volume. He had 6 liters a minute ago. Now it's down to 5.2 liters in blood volume. Which of the following are potential causes? A, dehydration, B, sodium deficiency, C, hemorrhaging. Of course, all of the above. If I decrease my blood volume, what will happen to my blood pressure? Decrease. So right off the bat, knowing this concept map right here, this part, you already picked up what? 2-3 questions already. And if you know where you start your stimulus, you know what's going to happen in the end. What's going to happen? If I'm dehydrated, what am I going to do? I'm going to fix it. So what's going to happen? The water is going to go what? Up. If I have a sodium deficiency, what's going to happen? The sodium is going to be retained. And if I'm having hemorrhaging, what am I going to do? I'm going to have increased blood volume. So this is the end part, and this is the beginning part. And we'll look at here. Increased blood pressure, increased blood volume, right? Increased sodium and potassium. So isn't that what we are deficient here? Now we've corrected it over here. So now you learn the beginning, and then now you learn the end. So let's now learn the middle. We mentioned the JG cells that were really close to our glomerulus, hence the term juxtaglomerular cells or JG cells. And we know they're inside the kidney. So there's a picture of a kidney. Actually, when I look at this, if I were making notes, doesn't this look like a J? And maybe I'll write a G here. Yeah, I could do that. Now, JG cells release renin. Now, renin needs to get activated. So you have this thing called angiotensin. Now, look at the word angio, blood vessel, tensin. So what's going to happen to my blood vessel? It's going to get tensed up because what do I need to do? I need to increase my blood pressure. Yes, question? No, we're good? Okay. So angiotensin, I could ask, what does it do? And you look at it and says what? Oh, it's going to increase my blood pressure. All of this is going to do what? Eventually do what? Increase my blood pressure, because what's my main problem? A decrease in blood pressure. So what's the end result? Increase. So renin will convert angiotensinogen to angiotensin 1. Angiotensin 1 that gets converted to angiotensin 2 through this thing called ACE, angiotensin converting enzyme, or just call it ACE. So what kind of question could I ask you just from here? Where do we get renin from? I closed my eyes and I saw the kidney that looked like a J. So that's got to be the JG cells. Where'd I get the angiotensinogen from? Well, there was a picture of the liver here on the left. And then I had a 1 and 2. The 1 turned into 2 because of what? The letters ACE in my lungs. Okay. So I could ask, where's angiotensin converting enzyme located? Lungs. Where does angiotensinogen get released? Liver. Where does renin get released? JG cells. Who converts angiotensin 1 to angiotensin 2? Well, an angiotensin converting enzyme, also known as ACE. Again, 4 or 5 more questions, not by reading the chapter, but by looking at this diagram and understanding what this diagram does. Now, angiotensin, again, use your medical terminology powers. Angio means blood vessel, tensin means what? To tense up. So what's going to happen? Vasoconstriction of my arterioles and my blood pressure will go up. Because what happens when you squeeze on a tube? The pressure goes up, right? And just like a hose. Now, do you see this adrenal cortex? Doesn't it look like an A? Looks like an A to me. So the adrenal cortex will release aldosterone. And what will aldosterone do for me? Increase sodium and water resorption. Because remember, because what was my problem? Is water and sodium deficiency. So what did I want to do? Increase blood volume. And it's right here. If I have too much potassium, what's it also going to do? It's going to tell me I need to do what? Because I take in more sodium and more water. And if I take in more sodium and more water, who do I get to throw out? Because remember, there has to be a balance. Potassium and hydrogen ion. So you can draw an arrow here and point that to the toilet. So you could see this whole entire thing. Good dozen questions, easy. And you preempt. So here's some other sample questions just from this part. My patient has an adrenal cortex problem. What can't they do? They can't release aldosterone, and they won't be able to do anything about my sodium or water reabsorption. So if I have decreased aldosterone, what will happen to my blood volume? It'll decrease, right? Let's say, for example, oh, I already did this one. If I throw out hydrogen ion into my urine, what will happen to my what will happen to my blood? So the first thing you could ask yourself is, okay, if I'm throwing something into the urine, I'm throwing it into the toilet, I'm getting rid of it. So if it's not in my body, that means I don't have a lot of H pluses. And if you recall your anatomy and physiology 1, right? Let me write it down. Or let's take a picture of it. Remember your pH? Where's a nice pH scale? So remember the question. Okay, here's a nice one. Let's actually copy this and put it in our Microsoft Word. And I'll have this Microsoft Word available for you guys. So I'm throwing potassium and hydrogen ion into urine. So let's say I'm neutral, right? And now I'm throwing a whole bunch of hydrogen ions. I don't have a lot of hydrogen ions. So if I move over here, that's increase. So I'm going to move away. So what's going to happen to my blood? It's going to get alkalized. But if I don't have any aldosterone, what's going to happen? I'm going to retain hydrogen ion. And then what's going to happen? I'm going to get acidic. This is another question I could ask that's related to your anatomy and physiology 1. Let's center this. This is annoying me. That's not centered. Okay, that's the best we can do. My patient has a pH of 7. They're neutral. If they have a pH of like 4 or 5, it's what? It's acidic, but slightly. Urine could be slightly acidic. 8 or 9. Urine could be also slightly alkaline or basic. But 1, like gastric acid, hydrochloric acid, very acidic. 13, 14, very alkaline. And if it's alkaline, what happens to the pH? It goes up, but the concentration of the hydrogen ion goes down. If something's highly acidic, the pH will go down. And what happens to the hydrogen concentration of the hydrogen ion? It'll go up. Okay, I hope that didn't add to the confusion, but play back the last 5 minutes if you didn't get this, because this is a really important scale that you should know regarding blood and urine and any of your bodily fluids, because where does human beings need to be? In the middle. Physiologic pH is around what? 7.4, which is around here. And that's all your body does all day. You're swaying back and forth, and it's trying to keep you here in a minute. Let us see if we went, and I'm going to save this. Let us see if we covered everything. Properties of urine, check. Structure and function of urine transport, how it starts in the cortex and then goes down to the medullary/papillary area and into the ureters and down into your urinary bladder through your urethra and in the toilet. Structure and function of the kidney. We already know the functions, and related to that is the nephron. We went over this diagram, which is the same thing as this video right here, which is the endocrine regulation of kidney function. We also now mention all of the kidney functions. And to recap, it not only filters blood, it reabsorbs it, it secretes it. It not only tells us, does all that, it also tells us when we're short on blood, so we can make more. It also regulates acid base. It also regulates blood pressure. It also regulates blood volume, and it also regulates salt retention and secretion. Wow. So you can only imagine what happens when one or both fails. And again, let me jump back on my soapbox. We're all crazy about this COVID, but kidney issues are preventable, and they're killing people by the millions, and they're debilitating millions more. But it's not sexy, and no one likes to talk about it. And that's why if you have any money, invest in DaVita, invest in kidney, in National Kidney Foundation. They're making money hand over fist because we as a people don't want to deal with diabetes, which is number one, and or blood pressure issues, okay, and which affect the kidneys. Oh, by the way, another thing that's on the rise is juvenile diabetic kidney patients. I don't think when I was in training, I ever saw one. But according to some friends of mine who are nephrologists, they see it all the time. And they don't even refer it to pediatrics. They just deal with it themselves because it's so common now. So on that note, I am going to stop the recording and then open the floor for questions.